Yes, good evening, all the participants. I'm Abdul Razak, the co-coordinator of this 1 week Aicte-Atal online FDB. Am I audible to you all, Manish sir?
Yes, sir. Absolutely.
Yeah. I welcome you all in this 13th and last session of our FDB. Today, our speaker is Dr. Sadaf Khateeb ma'am. She is medical officer at Indira Gandhi Government Medical College and Hospital, Nagpur. Madam has already delivered one session, and that was too informative. We are delighted to have Madam once more for the next session. Today's topic of discussion is intelligent medical appliances. So without any more delay, I request Madam to take over the session. Madam, please take over the session. Thank you.
Are the slides visible?
Yeah, ma'am, it's visible. It's visible.
Okay. So good evening, ladies and gentlemen. Today again, I take the opportunity to thank Computer Science and Engineering Department of Anjuman College of Engineering and Technology and the organizers of this FDP for giving me this opportunity to speak. In the previous session, I had logged out early, so I missed out and I couldn't acknowledge the feedback. A humble and sincere thank you to all the participants for their encouraging feedback. Now, carrying forward from the previous presentation, today we shall see the mechanisms of AI-powered diagnostic procedures in respiratory medicine, followed by a brief overview of AI solutions used in the TB elimination program. I will just rush through the demonstration videos of. This is from the previous presentation, the diagnostic procedures that I had elaborated upon: bronchoscopy, Ih&Ms TB-NA, TB diagnostic procedures, polysomnography, and spirometry. Of these, I would just rush through two virtual demonstrations: bronchoscopy and Ih&Ms TB-NA combined, and the other is polysomnography. Video शुरू है क्या? Visible है. What you have just seen is the bronchoscopy procedure, a bronchoscope inserted inside the trachea going right up to the division of the trachea where the two bronchi are there. A lymph node was already identified through USG ultrasonography. The procedure adopted here, the AI modality used was the navigation system, all being projected on the screen seen by the doctor conducting the procedure. So this was how a sample was collected. Needle inserted, sample could be the liquid sample sucked inside the aspiration tube, or as we call biopsy, tissues taken from the structure, which helps in further diagnosis. And as soon as we come to a diagnosis, appropriate treatment can be initiated. Now we go to the next video, which was of polysomnography. The previous one you saw was bronchoscopy along with endobronchial ultrasound with lymph node aspiration. Now here is a sleep study.
So what was seen here, it appears to be quite cumbersome. Wires attached to the head, to the chest, and sleeping with all the paraphernalia. It seems a bit difficult, but it isn't as difficult as it it seems to be in the video. And as you saw, and I had mentioned earlier, sleep apnea could be because of obstruction. The tongue throws back in the throat, blocking the respiratory passage, and the breathing breaks down, which results in a break in the sleep of the person. These are findings usually in obese people. As you saw in the video, the gentleman there also was on the obese side. So it's if need be, if there is sleep apnea which requires treatment, as shown, CPAP, continuous positive airway pressure, where oxygen is given through the nasal twangs, and a complete sleep can then be taken by the person with the help of, if one gets tested with this procedure and we come to a diagnosis that a treatment is required, then CPAP will help the person to have a sound sleep right through the night. And a sound sleep is very essential for a healthy lifestyle. These two videos were just a refresher for you from the previous day's session. We now move ahead to AI solutions for TB elimination. Pardon me, in the previous, here in the polysomnography, the AI technique applied is usually in the interpretation of the graphs of the waves recorded.
Here the AI comes into picture. And with both these videos, I would like to specify AI is not the modality which can go forward. Physicians' acumen has to be taken, I would say the physician's opinion has to be taken in view. And along with the physician's opinion, the physician's acumen, the AI technology will give good results. It cannot be either or. It has to be and the physician's work and the AI technology. So now we move to the AI solutions for TB elimination. Intelligent systems in healthcare have grown exponentially in the private sector. But when it comes to the government sector, there are many roadblocks. Though difficult, it is very critical to identify the problem areas and articulate the opportunities, because the public sector setup caters to a vast majority of the population. And even today, a lot of people, I would say more than 60%, 70%, cannot afford the private setups. They have to go to the government setups, to the public sectors to get themselves evaluated, diagnosed, and to be started on treatment for whatever the ailment. But TB is one such thing. So the Government of India, in particular, the Ministry of Health and Family Welfare, in collaboration with the Central TB Division, prepared a national strategic plan for TB elimination. The first plan was between 2012 and 2017. In this plan, a target was set for the TB elimination. One of the targets was reduction in TB incidence by 80%, meaning the number of cases, new cases that are diagnosed of tuberculosis every year, they should be reduced by 80%. To accelerate India's efforts to achieve this target, the Central TB Division incorporated advanced data analytics and AI in the TB elimination program. So, in 2019, we witnessed the COVID pandemic. This further paved the way for exploring digital technology in patient surveillance and screening. NLP, natural learning processing, is one technology. Natural language processing is one technology which was used, which is still in use in the TB elimination program. Why TB? Why am I emphasizing on TB and the role of AI here? As you see the TB cascade, the red are the new active cases diagnosed with TB. See the number there. Then we come to the next step. Here, the blue are the people who have opted for treatment. And the rest, yellow, missing people, missing patients rather, because they are diagnosed with TB, but they have not opted for the treatment. Reasons could be many. They have migrated, they have died, not willing for treatment. The state of denial is very common in our mentality, to accept that we have tuberculosis, we have contracted the disease. Be it any disease, but particularly for TB, the stigma is such that people initially have that they are already in that mode of denial that it cannot happen to me. Yes, somebody else could be affected with TB, but certainly not me. So here you see few people coming up on treatment, rest not on treatment. And of the people who have been put on treatment, there are few who complete the treatment. And as you see in the last step, from starting from initiation of treatment to completing treatment, the figure reduces. And the people missing out on the treatment increases. As I already said, the missing of treatment could be due to very many reasons, due to failure of the treatment which was giving, because maybe adverse effects because of the drugs that were given, the patient could not tolerate the drugs. Most times, patients do not report to the health system with their problems, with their adverse effects at home, and there are so many people giving them so many advices. So they stop treatment on their own. It only happens later that they again get symptomatic, they again have to come to the system. The whole procedure is repeated again. Now, this cascade, as you see, the missing patients or people are such high. Even if there are few missing people, it is significant because pulmonary tuberculosis is a contagious disease, infective disorder, where one person can spread the disease to others. So if you can see the number of yellow people moving around in the society, it is a threat to the society. Take the case of Mumbai. Mumbai is like a ticking time bomb for tuberculosis. The local trains of Mumbai, the buses, they are so overloaded. Imagine one person who has refused TB treatment, or who failed the TB treatment, or who had adverse effects, so he stopped taking treatment. Imagine in that fully loaded compartment of a Mumbai local, one person is such, and he happens to cough out. Imagine the spread. The spread is within the perimeter from where the patient is coughing. So one cough from an infected, diseased person can lead to the disease to so many other people. The bacteria will lodge into the mouths, the noses of so many people. So here in the TB program, AI is used at every step, right from the targeting of the population to the diagnostic procedures, to the treatment, and to the follow-ups. So this cascade is very important to understand, and it has grievous implications if we understand the severity of the disease. Going ahead, the TB elimination program has 4 pillars: how to prevent the TB, how to detect, how to treat, and how to build the infrastructure right from prevention to treatment to follow-up. Now, how to prevent TB? Here, as everybody knows of the saying, prevention is better than cure. TB is spread, pulmonary TB is spread, it's an airborne infection spread through the air. Somebody diseased coughs in your face, you don't even know, and you get the disease. But there is a difference between infection and disease. So here in prevent, we have 3 points: identifying high-risk areas or populations for LTBI. LTBI is latent TB infection. Latent could be dormant, is sleeping. TB infection. Infection is the presence of the pathogen, the microorganism in the body. Myself working in this program, TB elimination program, for past 12, 13 years, I've come across so many TB patients. So many have coughed in my face. So there are, I would say, more than 100% chance that I have mycobacteria in my body. But by God's grace, with good immunity, I have not developed the disease as yet. So you can see the difference. Being infected means having the pathogen or the mycobacteria in your body. And being diseased is when you have the symptoms, when you have problems because of that mycobacteria for which treatment needs to be taken. That is the disease. If it's an infection, I'm not symptomatic. I may not cough, I may not have fever, I may not have any symptom, but the bacteria is there in my body. And given an opportunity, my immunity goes down. because of some pathology, because of some physiological condition, then the bacteria will grow, give me symptoms, and I will land up with the disease. So this is the part. This is the chain from a latent infection to becoming into a diseased person. This chain should be broken. So disease will not occur and infection will be treated. As I showed in the cascade, people diagnosed with TB do not take treatment properly. Imagine the scenario where a person has no symptoms but is asked to take treatment to prevent the development of disease. It's very difficult to convince people, but this is what the TB elimination program has been doing. So for the prevention part, the other is the automated skin test reading. And as I said, the treatment adherence of LTBI. So first we come to the CYTB. CY is the short form for the word Cyrus Poonawalla. Almost all must have heard about him. He is from the Serum Institute, which developed the COVID vaccine. So as a tribute to that gentleman, CYTB. This is a skin test which helps in determining if the person is infected or not. So a purified derivative, a little liquid medical product, I would say, is injected. 0.1 ml is injected into the arm. And after 48 or 72 hours, between 48 and 72 hours, not beyond that, the reading of that site is done where the injection was given. The tuberculin liquid or whatever protein purified derivative is given, the injection once given, the area is marked, circled where the injection is given. The person is asked not to wash it, scrub it, or scratch over it. In 2 days' time, in 48 hours, the reaction of that liquid injected into the body is noted. We see the skin becomes thickened, it becomes red, and that diameter is mentioned. The CYTB that we now hear about is this almost the same as you people must have heard about Mantoux test, Montoux test or Mantoux test, however you would like to pronounce. Same procedure is adopted with a different solution. The injectable part is, the skin changes in the injectable part is read in 2 to 3 days. If the thickening of the skin is beyond 5 to 10 millimeters, this shows that the person is infected. And there are very many chances that later in life, this infected person may become a diseased person. So what is the intervention here? You give treatment. Now the person has no symptoms, but treatment is given to the person depending upon the regimen, could be for 6 months, could be for 3 months, so that later TB cannot develop, should not develop. So this is one diagnostic modality for LTBI, latent TB infection. And as I said, latent infection is something which shows no symptoms at all. Now coming to the next part, the detect part. In detection, the diagnostic modalities, examining chest x-rays, in the CYTB test, the AI used here, the skin reaction that occurs, a picture of this is taken and sent on smartphones where the AI technology reads the skin lesion, the skin changes, and gives a comment whether it is positive or negative. So this is how, on a large scale, this test can be done. Now to the detection or the diagnosis part, examining chest X-rays. In the previous session, I had mentioned about AI tools reading the X-rays, more helpful in the peripheral setups of rural areas. The other is targeted case finding, cough and voice-based screening, and reading of LPA tests. Now, what is targeted case finding? In targeted case findings, we have different geographical locations marked by AI, which seem to be endemic or seem to be having more TB cases. These areas are targeted for active case finding. Active case finding means a person goes door to door screening the people. The ASHA workers in the health setup are the biggest chain here. They do the most of the screening. There are certain areas which can be hotspots. They are targeted for active case finding, which means door-to-door screening. Screening, people are asked questions regarding symptoms, or somebody feeling not well at home, everything going fine, loss of the symptoms for tuberculosis. If it's pulmonary, it will be cough majorly. If it's extrapulmonary, whatever organ is involved, the symptom will be accordingly. If there is a lymph node in the neck, there will be a swelling in the neck. If it's an abdominal TB, it would be pain in abdomen. There would be disruption of, I would say, the abdominal habits, improper passage of stools, frequent passage of stools, nausea, vomiting. This is abdominal. If it's brain TB, it could be high-grade fever, seizures, abnormal behavior. So according to the system involved, the symptoms appear. So in active finding, door-to-door survey is done. And if we find people who are giving such symptoms, they are brought into the setup, they are investigated. If diagnosed, they are put on treatment. This is targeted case finding. This is the active case finding. The other part is the passive case finding. Passive is something when the person is symptomatic, has had problems for the few days, a few months, and they walk into the hospital. They report themselves. That is the passive case finding. Passive is already in progress. It's happening on a daily basis in the hospitals, public, private, whatever. So more importance is given on active case finding. Now, the other test that we had mentioned is cough and voice-based screening. For tuberculosis, the minimum duration of cough that we consider is 2 weeks. A pilot project was run with voice-based screening. Studies have shown that people with TB, diagnosed with TB disease, when they cough, their sound of the cough is different compared to a person who is not infected or not diseased with TB. So what was done? There is a designation of senior treatment supervisor in the TB cascade. The setup, the system which helps in the diagnosis and treatment of TB is one cadre which was allotted with this project. They were asked to record the voices of 15 people, 5 TB diagnosed cases, 5 random people walking in the OPD or in the hospital setup, remaining 5 people who had symptoms of cough but were not diagnosed with TB. So based on these studies, the AI application gave a positive or negative result. If the AI reported the sound to be indicative of TB, we don't stop there and just start the TB treatment. The patient has to be diagnosed first with a microbiological confirmation like the chest X-ray, or like I had mentioned in the previous test, in the previous session, tests are conducted on samples. So sputum is tested for through microscopy, through CBNAT, or through LPA. One, a diagnosis is achieved, then treatment is initiated. So this is one modality which is still upcoming. It has not been established completely. LPA test, line probe assay. This test is an established diagnostic modality, very reliable. A sample of the patient is collected, be it sputum, be it some lymph node aspirate, be it some aspirate from the abdomen, some abscess, or whatever lesion is there, tissue scraping is taken. That sample is processed and run in a laboratory. The line probe assay test takes 3 days from testing to the generation of report. Within 3 days, we get a report, and this report is analyzed by the AI models. It generates a graph, and that graph is indicative whether it is tuberculosis or not. And once the report is generated, it is disseminated in the field to be given to the patients. And wherever the person has been diagnosed with TB, treatment is initiated. So going back to the detect models, we saw the X-rays are there, targeted case findings, voice-based screening, and LPA tests. Once a diagnosis is achieved, a patient is put or initiated on anti-TB treatment. The patient has to be continuously monitored. Monitoring, personalized care via chatbots. One is the Arogya Sathi app, specially designed for the TB patients. Here, patient queries can be resolved. Information regarding TB is there. Once the patient has been initiated on treatment, there are mechanisms of adherence. When the person has taken his anti-TB medication, there are modalities in the Nikshay portal. Nikshay. This is one portal for tuberculosis. I'll elaborate on it in the next slide. It marks the adherence. The person marks the adherence, which is then recorded in the portal. And based on this, further follow-ups of the patient are designed. Now, with this personalized care, with the Arogya Sathi app, teleconsultation can also be done. We also have TB champions. TB champions are people who have already taken treatment for tuberculosis. They are treated, cured now, doing fine, and they come up as brand ambassadors. One big example, it may shock you, is the one and only Amitabh Bachchan. He's the brand ambassador for tuberculosis. You must have seen advertisements. TB harega, desh jeetega. There are so many advertisements featuring Amitabh Bachchan. He himself had to take anti-TB treatment. And being the legend he is, such a popular personality, for him also, it took almost 10 to 12 years to come out in the public domain and accept that, yes, I had been infected, I had been diagnosed with tuberculosis, though it was an extrapulmonary one, it wasn't the pulmonary TB. But despite that, it took him 10 to 12 years and to accept in public domain that I was diagnosed with TB and I have taken anti-TB treatment. See the stigma. Such a well-read and known personality being hesitant to accept the reluctance, the denial, or could be he must have assumed that his social status may be affected because of his TB diagnostic. If he had accepted in public that he has TB, it must have been his thinking, fine. So now collate this to the general population. Even in cities, people are reluctant. And if it's a female patient, it's all the more petrifying for them to come up in the open. For the patient, the family also. Stigma still stays. This stigma, if it doesn't go away, it doesn't help us. We don't achieve the target of TB elimination as set by the global standards for the year 2030. And for us, Indians, our Honorable Prime Minister had set the target 5 years prior, 2025. It's a Herculean task. It seems almost impossible to achieve this target in 2025. But on our part, we can do a little social work. Wherever possible, you can help dissipate this stigma. If there is a person who has symptoms, encourage them to get diagnosed, and if diagnosed, to initiate treatment. And if initiated on treatment, complete the treatment. See, any drug taken can cause adverse effects. A simple paracetamol that you take for fever can give you side effects. Tuberculosis drugs. For a drug-sensitive TB, the treatment regimen is for minimum 6 months. And if there is resistance to any of the tuberculosis drugs, then the regimen that we put the patient on lasts for almost 1.5 years. It's so difficult to stay motivated for 6 months or 1.5 years to take tablets every day. And the number of tablets for a drug-sensitive TB, depending upon the weight band, the normal weight band, I would say, is between 30 to 50 for the TB patients. So it's 3 pills per day. But the size of the pill is big enough to put off the patient. But you have to monitor them, motivate them to take treatment for complete 6 months. And if it's a DRTB, for 1.5 years, 18 months to 20 months. And the number of pills, the number of tablets there is 13 to 17. It's as good as taking a bowl full of medicines for breakfast daily. Very difficult. So these chatbot-aided personalized care systems, they give reminders to the patient. They inquire about the daily use of medicines, whether the adherence is there or not. And if there are adverse reactions because of the drugs or for some other reason, they are encouraged to report to the health system. Then there are follow-up schedules planned for these people. These personalized care systems have those follow-up schedules. The patient is informed personally also by the treating staff when to report to the system and how to get the follow-ups done so that a complete treatment is taken and the person is cured of tuberculosis. As I said, Nikshay, Ni and Nikshay. Ni is no, Kshay is TB, I'm told, in Sanskrit. So it's no TB. This is one portal which is very handy. It is hugely used by the TB staff. And this on the right side, the screen of the Nikshay portal. When you open the app, this is the screen you get. Now, as you can see, new patients can be enrolled. Patients on treatment can be searched. What tests they have undergone, that can be seen. Sometimes it happens that the diagnosis is still pending, the report is awaited, has not reached the person. And once the person has been diagnosed, but the person has not come on treatment, so not on treatment. On treatment patients who have completed their treatment, they have been assigned outcomes. Whatever the outcome, treatment completed, cured, lost to follow-up, failed the regimen, whatever. So you can see there are so many parts of this which are attended to by the TB staff, taking care of the TB program. This Nikshay dashboard and all these parts of it help in tracing the patient. This can happen at the local level, at the state level, district level, state level, national level. How it happens? A person who is diagnosed with TB or who gets tested for TB is given a unique number, a Nikshay number, we say. Now this Nikshay number, when fed into this portal, you can open up and see whatever you would like to see, whether the person is on treatment, whether the person has undergone some tests, has the patient completed treatment. This can happen once the patient has completed treatment. The data is already fed. Now the person may come to you 2 years later, maybe 6 months later, or maybe 5, 10 years later. But we still have the data with us. So this is of immense help. The Nikshay portal. Now, resource planning and data collection. As I showed in the Nikshay portal, data is collected from different sources, from the field, from the Nikshay portal, and could be from the government machinery, say the district collectorate, especially the geographical data. Where are the hotspots? All this is incorporated, is collected, and the AI models are prepared, which areas to be targeted, what treatments to be initiated, how to be monitored. Now, all this up together put into place so that a proper treatment, a proper setup may be given to the TB patient so that a cure is achieved. Once, and same with the LTBI, latent TB. Target people who are not symptomatic to AI mapping, target those people, especially in the private sector. In the public sector, government setups, we have complete details of the patients. Now, when we come to the private sector, data collection is a huge problem. Simply, one example I would quote here, in Nagpur. Nagpur is centrally located. The private sector doctors here cater to patients from other states. It could be Chhattisgarh, it could be Andhra Pradesh, Jharkhand. There is very much migration from Uttar Pradesh and Bihar. So people visiting their relatives come here. If they develop symptoms, they get tested and then they go back. So it's so difficult to trace them. And once diagnosed, for latent TB, the major cohort is the people diagnosed with TB, their household contacts. Nothing extraordinary here. If a person is diagnosed with TB, the risk of getting TB amongst his near and dear ones is the highest. Because once a diagnosis is achieved, that takes time. Once symptoms develop, the person goes to the nearby quack. Few days of medicines are given. Person feels fine. Medicines are stopped. Say a week later or 15 days later, symptoms reoccur. Could be in a worse form. So now they go to an MBBS physician or maybe to a specialized respiratory medicine specialist. Once they reach there, see the duration of time, 15-20 days have already lapsed. The person already has symptoms. He now reaches a specialist where the proper investigations advised, be it sputum testing, be it X-ray. Along with that, antibiotics are given. Now the results have not yet arrived. X-ray report you can get immediately. The sample report may take 24 hours, 48 hours. It could be more. And even if the report is generated, the person does not go back to the laboratory to collect the report. So that further delay. Now, once the diagnosis is come at that the person is suffering from TB and treatment is to be initiated, almost 15 to 30 days have passed in between. In that duration, the person has been spreading the disease, coughing out. And when the person is diseased, he is mostly at his home. He doesn't move out. So the risk of spreading infection to your near and dear ones, to your family, that is the household contacts, it is very high. The other setting where the risk of spread is very high is congregate settings or workplace settings. Workplace settings, we have AC chambers, AC offices. So all doors and windows are closed, no cross ventilation. Somebody infected or diagnosed diseased with TB coughs out, and the air inside gets contaminated, and that contaminated air is being breathed by all people inside that enclosed chamber. So workplace spread also is very common. And as I said about congregate settings can be hostels, madrasas, old age homes, mental hospitals, jail inmates. There is a lot of people staying together. So all this literature is or material, the data is collected. AI helps in identifying these hotspots, and these are then targeted by the TB staff. So from all the presentations, the points that I have covered, what seems to me as the take-home message for everybody, AI technology learning should be integrated into medical education curriculum. Better late than never. Medical education has still not incorporated the AI part. The students are taught everything from the prevention to the diagnostics to the treatment and the follow-ups. Everything is maintained. But use of AI, this is all on a personal front that the students are aware. They are learning on their own. But if it's incorporated in the curriculum, it will be a great boon to the students, which will help once they come out in the field and start practicing as physicians. AI has the potential to improve quality and efficiency of patient care. And the third, AI will decrease the documentation burden of health establishments. We all know that with the analytics, data analysis, and with the automation processes, AI cannot be beaten. Humans just cannot match with the AI results. So this coming to the last slide. I don't know whether this is really said by Albert Einstein, but it has become appallingly obvious that our technology has exceeded our humanity. From this, what I make out, Albert Einstein had a time machine fit and he could see the 21st century. More precisely, after the 2020s, the boom in the AI. This is so true that technology has really exceeded humanity. But technology is equally important. So I here stop and thank you for your patient hearing. The field is open for questions. Any queries? Any questions in the chat box?
All the participants, if you have any questions, please post it on the chat box so that I can read it for the ma'am. No questions, ma'am. So, on behalf of Computer Science and Engineering Department, Anjuman College of Engineering and Technology, Nagpur, Maharashtra, India, it's an honor for me to thank Dr. Sadaf Khateeb ma'am, Medical Officer IGMC, Nagpur, for accepting our invitation and for sharing insights of intelligent medical appliances. From a physician point of view, many thanks for your contribution to this FDP program, ma'am. Also, our audience come to know about the ground truth, how the physician works at the ground level. Thank you so much, ma'am, for your presence. Thank you.
Thank you so much. Log out कर जाऊं? शुक्रिया। अस्सलाम वालेकुम।